out. I don't know the name of the mom was like dreaming and she was like looked like she was falling and I just want to know, was that scene kind of not depersonalization, derealization? Was that what was being portrayed when she was kind of outside of her environment?
So I guess first and foremost, describe what you saw.
Okay, so it was not in her house. It kind of showed her falling in some kind of like cloudy environment. My memory is a little off, but she was not in her home and she was moving somewhere else.
Yep. And well, I want you to re-ask your question, and then I want you to provide the answer in terms of what clinical term you think applies.
So the two terms that came to mind is this depersonalization and derealization. And it didn't look like she was outside of her, like she was looking at herself. It looked like she was outside of her environment. So I think that's derealization.
Okay. And if she were to report that, yes, I think the realization would be the single best answer in terms of the subjective sense that her environment somehow is unreal, or that she's disconnected from her environment. And maybe the metaphor there, the symbolism of the smoke, right? That said, if whatever it is reoccurring, and let's also say that an even easier example of this would be deja vu, right? If it were reoccurring and clinically significant, that for Amelia, it results in clinically significant distress or impairment in functioning, then what's we'll say that provisional diagnosis as a clinician you might?
Somewhere along the dissociative. It's dissociative disorder. There's a word missing, but it has a few. So there's like it's a bigger umbrella of disorders within it, or dissociative identity disorder, dissociative amnesia.
Depersonalization, derealization disorder.
Yeah, so that would be
There's your provision.
yeah.
All right. Single best answer shelf exam would be depersonalization, derealization disorder, which is a condition that encompasses aspects of depersonalization and or derealization that are clinically significant, right? In clinical practice, you would put that down as your most likely diagnosis, that is beyond the provisional. If and when you investigate other conditions and they rule out, and there are, I would say, 4+ here that we have to discuss. What are they? In no uncertain order.
PTSD.
That's one, right? I don't want to reserve that one for last, right? So now we're looking at 4. That was my plus.
Plus 3.
So that wouldn't make my top 4. As applied to Amelia, yes. But let me just take a step back and say, generally speaking, outside of the Babadook.
I think you said something about looking at dissociative disorder and I forgot what else you said right now.
Dissociative amnesia.
Yeah, that's number 1. So if Amelia gave us this history and that you just got up from your psychiatric interview and are perhaps around this table, presenting it to an attending, your provisional of depersonalization, derealization disorder would not be incorrect. However, it would be if Amelia also told you that she has gaps in memory, that you feel that you could not simply attribute to ordinary forgetfulness. Because then I'm hearing it sounds like dissociative amnesia, right? And dissociative amnesia does in fact incorporate aspects of depersonalization and derealization. That is, what the patient presented with in that scene is actually explained for by that larger illness.
Okay.
All right. So that's 1. 3 more. I already heard another one.
Yeah, we
There.
had it earlier.
Dissociative personality disorder.
Exactly right. So if you came in here and told me, all right, Toby, it looks like this is dissociative amnesia. And the reason why this individual, maybe Amelia, maybe not, is suffering from these gaps in memory is because that it's a distinct personality state that takes over a conscious awareness. I would say, whoa, that's DID. That's a condition called dissociative identity disorder, or DID, which accounts for both the amnesia and aspects of depersonalization, derealization, that is, everything can be attributed to that larger illness.
Mhm.
So there's a hierarchy here.
Mhm.
And it's because of that, that both DID and associative amnesia preclude a diagnosis of depersonalization and realization disorder. Two more. Danielle's got to, yeah, or she can. She's heard this before.
Be anywhere along the spectrum of like schizophrenia, schizophreniform.
Potentially, now my top four then. And these next two, I want you to write down because you're going to apply this to every single case we discuss for the next 5 weeks. You guys? Those due to an effects of a substance or an underlying medical condition. Because the psychiatrist is not going to render a diagnosis of a mental disorder until those quote unquote organic etiologies have been investigated and ruled out.
So substances like the number one on this would be maybe PCP or any other.
I want you to tell me the 5 on your list. So PCP hallucinogens are 1, 2,
Super high payment, like oxycodone, like very high dose. I don't know.
opioids are not on it.
Cannabis.
Great.
Yes. Alcohol.
4, and anything alcohol does, for all intents and purposes, benzos and sedatives can do so. There's an exception here, don't worry about the exception. One more.
Okay.
Cocaine we said.
Okay.
Stimulants, yeah.
LSD, was that included?
Yep, the hallucinogens we got.
Like ketamine.
Hallucinogens we got.
Are we only talking substances?
Yeah.
Levodopa, like Parkinson's.
Yeah, but that's not
Dopamine.
substance, it's that.
Oh,
But believe it or not, there's a little bit of differentiation. That's why the American Psychiatric Association in this chapter, and you're not wrong, says substances / medications, because both are contained. So there are meds that do it too. We're not going there. I'm looking at the substances right now. So again, this is where, and these guys heard me say this before, I know you're going to break my heart in a matter of 3 seconds. Who here has seen Paranormal Activity? Yes.
it was like my entire middle school.
Early week.
You know,
Who's the main character in the original? Main
Katie?
male character, you're right. Katie.
Micah.
Okay, how does Micah spell his name?
MICA. H.
Perfect. You just gave me the acronym. Now, for those who have seen this movie, you know that this is all told through the perspective of Micah, right? So I have him billed as the main character, although the true main characters are Katie and Chrissy. But the main male character, the one holding the camcorder, the video camera, is Micah, MICAH. There's your acronym for the substance-induced psychotic disorders. Right, so now that you know that, you're missing the I.
And Helen,
Is it? Okay. All right, so getting to your original question about Amelia. Yes, this looks like an aspect of derealization. However, until we investigate dissociative amnesia, dissociative identity disorder, dissociation / psychosis, and as far as substance induction, same thing. What can induce dissociation also induces psychosis and vice versa, as well as that due to an underlying medical condition. We would not arrive at that diagnosis of depersonalization realization disorder. Those 4 must be investigated. And then we have 5 or plus, and that conversation is much too broad to discuss here, but it starts with post-traumatic stress disorder. And then it does evolve to other conditions, including the schizophrenia spectrum and other psychotic disorders. So it's a much larger discussion, we're not gonna have it here. Unless aspects of Amelia's behavior have us circle back to this, right? But to start, we have aspects of derealization. Is there any evidence of substance use in this film? And I'm gonna ask this twofold. So if you've nerded out and you put up the script, and you go to the search function and start typing in mica, right? Methamphetamine stimulants, inhalants, cannabis, alcohol, sedatives, hallucinogens, mica. What do you come up? All right, good. And that's very similar to asking a patient, can you let me know what substances you used over the past 2 weeks since the onset of these symptoms? Right, when a patient tells you no and that search function comes up, you have to go to the next step. And that next step is maintaining a high clinical index of suspicion. That is, you believe it's going on anyway, despite your initial inquiry. So beyond that search function, when you begin looking for clues, does anything come up? And this is where symbolism, reading between the lines, all that fun stuff that goes into watching a movie, motifs, anything consistent with substance use. So I'm going to the collective response, I'm not hearing now.
I think the mother had trouble sleeping, so she brought her son to the doctor, and I think they were given benzos. I don't remember exactly what it sounded like, but then she was, the child like didn't want to take it at one point, which is like, you have to keep it.
All right, so there's a couple of ways, a couple of teaching points in this, right? And that is, again, circling back to this diagnosis, and this comes up on shelf exams all the time. Substance-induced mental disorder, and in this case, it would be a substance-induced psychotic disorder. The word psychotic, when it comes to substance induction, is the overall term the APA has chosen that includes the association. All right, so in terms of that temporal relationship, what does the APA require for you now to look into? What do you have to look at your case vignette on that shelf exam to establish cause and effect? That is, a substance is in fact inducing the symptom.
The timing.
More specific.
It only occur when they use substances. Did it occur after they use substances?
I want to know what you need the operation defined after or while.
Well, so typically if someone telling me they would have hallucinations, delusions, or hallucinations before they ever started using drugs, then I'm not going to consider it a substance use, even if with the drugs and they maybe have more intense hallucinations.
Definitely true, but the board exam is not going to give that to you. They're going to tell you it's the next number of days / weeks / months ago. What's your cutoff?
Does it depend on the substance and how far?
It kind of does, but the APA has a specific time frame during which you can actually make that diagnosis. They're going to test you on that time frame. It's 1 month. Within a month of use.
And is that, that 1 month is the same for both like, new users and people who have been using drugs for a long time?
Yep.
So the 1 month is applying to they've taken something, or is it like, can you clarify like what clues we'd be given?
If there's an onset of symptoms within a month of use, it is a substance-induced mental disorder until proven otherwise.
Okay, so you know that there's some kind of loose.
Right? I mean, if a person tells you, yeah, you're using pills, well, when was the last time you used? And now, and again, this is reliable, right? So I'm not trying to trick you. And they say, oh, back in 1990. You cannot establish cause and effect. So the question then comes, well, when can you? And the answer is 1 month. And that's both intoxication and alcohol. 1 month. Now, there's another teaching point to your observation, and that is quite clearly, we see the child begin to exhibit symptoms prior to being taken to the doctor, because of the symptoms. So it's hard to establish that in this case, Samuel has a substance-induced mental disorder, right? But that doesn't mean that substances don't play a role here. So we have to talk about the role. Most of us, I think, feel comfortable in discussing the biopsychosocial factors that influence behavior and therefore abnormal behavior. I want you to get comfortable and also looking at what we call the 3 R's. Nope, the 3 B's. Scooby-Doo. There are those factors that predispose, precipitate, and perpetuate the illness. So while the precipitant may have predated his getting those sedatives could still play an active role in that they are biological perpetuating factors. They're exacerbating, further exacerbating, perpetuating. Right. And the next practice exercise for you is that when you take notes, when you do a psychiatric evaluation and you take notes, before your presentation, if you were to build a 3x3 rubric, right, biopsychosocial across the x-axis, creating 3 columns, and then PPP, predispose, precipitate, perpetuate, Y, 3 rows, and begin to retranscribe all your notes into those 9 boxes as best they fit. You can really see the etiology of drones. You can see those influences. And in this case, benzodiazepines would be biological, first column, perpetuating, right, third row. Those that predispose, precipitate, perpetuate. So just because we, and rightfully so, observe that now Samuel's symptoms predate his going to the doctor, this can't be due to a benzo, pump the brakes. Benzos can still play an active role. In this case, it will be as a biological perpetuating factor. That's 7 box. By the way, these guys run their group runs a didactic on Instagram called Formulation, where they just post those 9 boxes every week, and you got to guess the fictional character. So if you want to keep your mind mentally sharp and really thinking of those 3 P's combined with the biopsychosocial formulation, check them out on Instagram. All right, all from Amelia. Right?
All right, so you said this framework is good just for kind of identifying a cause of psychosis, or can you apply it to anything?
Well, anything, you can apply it to your sibling also.
Like a cave conceptualization tool,
Is that?
like a cave conceptualization tool.
Yeah, it really gets important for treatment plan. Because you really then focus on exactly what element, what stage of symptomology you're really addressing.
Going off that too, I'm kind of the role of grief in this presentation, right? Because there's this unresolved grief that's like, probably at this point, taking prolonged grief disorder diagnosis.
So let's start simple. Let's start with the concept of bereavement. Right, so now, of course, we're primarily focusing on Amelia because of where we started. Let's continue to focus on one character. And I'm going to say very little about Samuel because I'm just not a adult psychiatrist. So I think most of the teaching is going to come from the adults in the room, in the film. What is bereavement? I think it's fair to say that Amelia is bereaving. She's grieving. What is this concept, bereavement?
Being over a lost one, and sometimes you might want to have like, I mean, but it's important to distinguish bereavement from major depressive disorder. Like for example, they might have like thoughts of like wanting to join them and anything like that, the person who died, but not necessarily a suicidal ideation.
So what I'm taking from what you said is that it is a culturally sanctioned and normal response to dying loved one. Right? And that's where we have to start, normality, right? We always assume that when our patient is telling us unconditional positive regard is the norm until proven otherwise. So I want your mind in this film to start with, especially in focusing primarily on Amelia, 3. Now, bereavement could go through several stages. Can you give me those stages? Because they could show up on a shelf exam. Denial, absolutely.
Anger.
Anger, Bargaining. Acceptance. And. Depression. Right. Number one, they don't have to go into any certain order, even though they were certainly initially proposed as going through some linear order. That is not the case. People can actually become stagnated or fixated at a stage. They can skip stages. They can certainly regress back to previously seemingly resolved stages. And this this series in any way, shape, or form doesn't necessarily only apply to the death of a loved one either, but other conceptual losses as well. So a breakup, divorce, or other. Here, of course, we have spoon fed. It's due to the death of a loved one. What stage? At the beginning of this movie, anyway, is Amelia at?
There's a lot of denial, like her sister talks to her about you won't even say his name.
Yeah, so she's early on in the process. Now, both qualitatively and certainly quantitatively, things can evolve from here. Right, and the American Psychiatric Association in 2013 captured that with a new diagnosis published in the DSM-5 called persistent complex bereavement disorder. Mouthful. If you say complicated bereavement, we know what you mean. So, what is this condition?
It's kind of like it's like abnormal grieving over like an extended duration of the year that's like more than 6 months after the patient or the loss occurred.
No, I think the major thing to remember here is one that is qualitative, and that unlike bereavement, this is abnormal, right? It results in clinically significant distress or impairment. Hence the reason why the word disorder is actually slapped on the label. Right, that's the main finding here, right? So it's we try to de-emphasize timing,
Okay.
And duration. We want to de-emphasize the quantitative value, but the qualitative value here, and that is there's clinically significant distress or impairment in functioning, which makes it a disorder, right? Persistent complex bereavement disorder.
But I do think in 5DR, they do say at least 12 months.
Yeah. My gut says it's been 6.
It'll probably change again, yeah.
Yeah, I really do think the trend is to de-emphasize that. We're really trying to meet people where they are and look at this qualitatively. And of course, this condition poses risk for developing major depressive disorder.
I think that's one of the criteria too, if someone's better, like the diagnosis is better captured by MDD or by other diagnoses, then you wouldn't diagnose it in the same complex bereavement or prolonged.
Right. If you're diagnosing persistent complex bereavement disorder, the individual should not reach diagnostic criteria for major depressive disorder, right? Which is a discrete change in functioning hallmarked by 5 symptoms over at least a 2-week period. One of which must include either depressed mood or loss of interest / anhedonia. So I think the Babadook as a movie begins to serve as a fictional case of this evolution from normal bereavement, which is a little redundant, bereavement, through persisting complex bereavement disorder to major depression. Now, what are the different severities of major depressive disorder?
It depends if you have suicidal ideation or not.
And if the individual does, what severity would you tackle?
Very severe.
So, okay,
There's mild, moderate, severe. Imminent.
very
Oh,
close.
psychotic features.
That's it, right? So there's 4 different stages here, 4 different levels of intensity: mild, moderate, severe, and then severe with psychotic features. Sometimes, again, a little bit redundant, severe without psychotic features would be level 3. Severe with psychotic features. Which then begs the question, is the Babadook a figment of Amelia's imagination brought about by perceptual disturbances due to a major depressive episode, severe with psychotic features? I think, spoiler alert, the ending kind of supports that in as much as it might be, that is the ending, conceptualized as her regressing back to denial. Feeding that monster, feeding her demon. So she remains stagnated, or at least regresses back to denial.
Yeah, I was seeing it more as like acceptance, like she has to live with it and she can like live in peace with it now.
You know, depends how dark you are. I guess it's a little more happier.
Yeah.
Yeah, maybe self-disclosure, I look too much at myself. So the producer of Babadook comes and speaks with us as a group and says, you know, I want to do a Flash Sideways. I want to make another movie in which this person gets help. And therefore it's going to change the narrative. It's going to change the actual plot course of this character development. What are some things that you're going to inform the writer producer to include in this sequel? This reimagined outcome.
Changes in appetite. and Motivation, you kind of see that, I guess, when she's like not eating the food, but they have class in it.
I want you to infuse some treatment modalities here, resulting in a different outcome, and what that outcome would look like. Second part's more creative. I just want to keep the brain. But more importantly, for shelf purposes, what are some of the treatments that are available for major depressive disorder that we could add to this film in this remake?
Well, for her specifically, I want to do trauma focused CBT because she has this trauma of the accident. I think it can be addressed. If there's some kind of trauma focused treatment is absolutely necessary.
Yeah, right. So I think, again, we think biopsychosocially and certainly psychologically, a referral to therapy and our goal and address CBT, trauma focused CBT.
Right. Does it fall under psycho or social, but like a group support group for people losing house.
Absolutely. Yeah, I think that's a pretty pervasive theme, is that she has no support here. Even her sisters are strange, right? So absolutely. Yeah, I think it'd be fair to say that's a social support. So thinking biopsychosocially, a referral to a support group in addition to therapy.
Sorry, I didn't even mess with her.
Yeah, I think that, you know, if we're gonna author this, I think midway through the movie, I think both would not achieve the desired effect. And probably gonna have to do something on a biological or somatic, which would include an antidepressant. Right, so, generally speaking, the good news here is that all the antidepressants are equally effective. So you can flirt at anything you want, and be right. That's a good news in terms of efficacy perspective. However, it's a coin flip in that 50%, only 1 in 2 will actually have a response to the initial agent. We can improve those outcomes by making sure that we understand that quote unquote chemical imbalance, the neurotransmitters involved, and evidence that one system is of greater value in addressing dopamine / norepinephrine versus serotonin than the other. All right, so during a routine psychiatric evaluation, your patient's going to give you clues that it's more norepinephrine or dopamine versus serotonin, or vice versa. And if you pick up on those clues, you have a better chance of having them respond to your first choice of medication. All right, so what are those serotonergic clues beyond CDS? And is Amelia demonstrating? So number 1 is anxiety. Anxiety is a serotonergic phenomenon. So if you ask a patient during a routine psychiatric evaluation, do you consider yourself a nervous person? That is a wonderful one question screen with significant negative predictive value. Patients who say no don't have an anxiety disorder. 99%. However, if they say yes, obviously you have to store that in the back of your mind for multiple reasons. One is to, of course, evaluate for an anxiety disorder. It's a positive screen. But the other is choice of medication. Your patient says yes, and you don't choose an SSRI, you don't choose a serotonergic agent, you missed it. Okay. Other evidence that it's the serotonin system that is misamplified here, other than CDMs. Comes up in exams all the time. What metabolite is found in lower levels in the CSF of patients with complete suicide? 5-HIA. Very common test question. The look on your face, did you see that in test recently?
I don't know.
Yeah.
I don't know. Alright, but I can remember the letters.
That's fair.
5 something.
Also, that's the metabolite of serotonin,
Mhm.
right? So the person tells you past psychiatric history, again, part of the routine psychiatric evaluation. Yes, I had one prior suicide attempt, they're telling you it's serotonin problem, doc. So get that, translated on, because that's what you need to hear. So anxiety, a history of suicide.
I just want to clarify, you said, the anxiety is that caused by too much serotonin or not at all?
Then,
Yeah. 'Cause I don't know, I read somewhere that, when you give an SSRI, it can exacerbate anxiety. It's the only reason I'm like.
we could talk about why.
Okay.
Well, it's a little out of the scope, but
Yeah.
we'll definitely discuss why. The final one is actually found in the diagnostic criteria for depression, sleep. But the time you'll check this box is when the patient tells you that there's difficulty sleeping with insomnia, but it's outside the context of the current depressive episode. That's a biggie. So, Amelia will tell you I've been feeling this way since the death of my husband, but I've been on Ambien since I've been 16. That's a serotonin problem. There's something going wrong with our serotonin system. Those are the big three. And again, if your patient endorses one of them, your choice of agent should include modulating serotonin. On the other hand, we're looking for additional signs and symptoms clues. That this might be a norepinephrine / dopamine, it's the same pathway. This equilibrium, this amplification. One of them is also containing the CDCAP's concentration. But again, only outside the context of the current depressive episode. So again, I've been depressed since the death of my husband. But I was diagnosed with ADHD when I was 4. And that's concentration. There's inattentive. Obesity is a norepinephrine manifestation. Tobacco use disorder. Alcohol use disorder. Matter of fact, I'd even get even more conservative. Positive cage screen goes in from here, heavy drinking. And then finally, substance use. And I fall short of saying substance use disorder, just substance use, using substances. That's a norepinephrine / dopamine problem. So again, if they endorse any one, you can't ignore the norepinephrine and dopamine system. So obviously, if you're in both columns, you're going to go with the combined agent, right? Dual agent. Where's Amelia? Knowing what you know now, you're building this sequel. What are you going to give her? Why? She's smoking. Smoking, smoking. We already said no drugs. It's not obese. Again, you want to be conservative here, even overweight, BMI 25 or higher. Difficulty concentrating? And-
I would say yes, but
Open on outside.
Yeah, that's the difficult part. We don't know that, we don't know the prequel. Yeah, so that's a half a point. Similarly, difficulty sleeping, right? But again, half a point. Changes. Right, so she's serotonin definitely. So the conversation now is, we have a choice, right? We're checking that serotonin column. We have a choice between any SSRI, all are equally effective. or even trazodone, which is Deseret, right, which also hits serotonin, albeit at the receptor level, so no choice. Now, trazodone or Deseret is poorly tolerated. And unless we want her to sleep, we have to move it. We're probably gonna go with an SSRI. So it has nothing to do with efficacy, but side effects and tolerability. Now, the question is, if we're starting with an SSRI and we're thinking, I don't know about this thing, this concentration. We might just say, let's go with a dual agent, just to be there again, we could look at inhibiting reuptake, or we could look at the receptors. The SNRIs, the serotonin and norepinephrine reuptake inhibitors, start with venlafaxine, the first approved. And the one that hits the receptors, again, dual mechanism, receptor level, would be mirtazapine, which is Remeron. So again, all the above are equally effective. So let's say we start Amelia on mirtazapine. Yeah, let's just go with this, and then we'll continue with the conversation on treatment in general. Mirtazapine. And with about 20 minutes left in this movie, Amelia is 35 pounds heavier. Right, weight gain is a significant side effect. And she goes in, and they're going to cast you in the film. You have a cameo. Wear my jacket. And they ask you, hey, listen, and they're going to ask you to improv the scenes. You can't read from the script, so you have to take what you learn from Utopia. And they're going to ask you, listen, here, the options are that you just continue the medication. She's actually feeling better. So her symptoms are not 100% resolved, but if you look at the That's Depression Inventory, her score is certainly dipped about 10, tick below 10. And there's a 50% reduction in total symptomology as per the DDI. So she has a response. And she feels better, but she's not back to this. 35, 37 pounds heavier. You can just continue the medication. You can stop it now. You can switch it. You can increase the dose. You can decrease the dose. So there's 5 options. It's an improv doc.
Yeah, maybe.
And action.
How concerning is the weight gain?
37 pounds is concerning.
Oh, like to her.
Oh, she's going to give it to you.
Okay. Maybe decrease the dose and see if it still controls the depressive symptoms.
Decreases the And the cool thing about this scene is that you've got Robert Wood Johnson medical students actually rotating with you. So having entered the room, and the patient looks at them and says, "Are we done?" And do the medical students have any further input here?
Bupropion help with weight loss.
It does. I'm sorry. Option number 6. Add something. Thank you. Thank you, Ryan. That wasn't fair. Anybody else?
I do like decrease the mirtazapine.
Yeah, little Samuel looks at his mom and says, "Those medical students make that doctor change his mind." What you got? Anybody else? Anybody differ in opinion? I heard something here.
We should consider changing it.
Changing it and an increase. I got an increase, I got a change, I got an add, and I got a quasi lower
Got all the answers.
aspect. I'm covering the field here.
Well, my fear is increasing it if it's causing weight gain.
And that's why it's the correct answer. It's because we want you to get that question wrong. Right? This is a dose-dependent receptor affinity. At that start dose, it's an antihistamine and a significant appetite stimulant. And what we failed to do was, after a day or two, titrate that dose to 30 plus as quickly as tolerable. Right? Because as soon as you get past 7.5 and you hit 15, you get some antihistamine, but now you're picking up serotonin. And at 30, this becomes an SSRI. At 45, it becomes a dual agent. It's an SNRI. And then at 60, it's a norepinephrine agent. Right? Dose-dependent receptor affinity, which is why at the start dose, you're going to get increased weight gain, significant weight gain. And when given the opportunity, you're going to increase the dose, which is incredibly counterintuitive, which is why it's a very, very common test question. All right, what medication is your final choice and why? Of course, the hint is it's not going to be Reducible. Single med for the treatment of Amelia. What's the diagnosis again?
MDD with psychotic features.
Okay. Single agent. What do you got?
Does it have to be medication?
Yeah. No crystals or Ouija boards. No exercise and being Babadook. Very common test question. Amoxicillin. What's amoxicillin? Tricyclic antidepressant, which means it hits serotonin and norepinephrine. But it also has an additional mechanism beyond that, which is what? You can look it up.
Most generic.
Amoxicillin, I think it is generic. Is it Ascendant for branding? I don't know. For branding.
It's a, so that,
Oh, sure. Does it get a mechanism in? Focus.
Somebody said the psychotic depression, so.
Was that?
Psychotic depression.
Yes, it's also a
Sleep, energy.
it's also a deep sleep mechanism.
Yeah.
It works in the top. So if you're asked, and it comes up on exams, amoxicillin for psychotic depression, amoxicillin for major depressive disorder with psychotic features, because not only does it hit the catecholamines, which would alleviate the depression, it's also a D2 receptor antagonist, which is the same mechanism of the traditional or first generation antipsychotics, such as Haldol, and you address the depression as well. In a psychotic depression or MDD with psychotic features, if you only gave that neuron, about 20 to 30% would get better. If you only give antipsychotic, about 20 to 30% would get better. If you gave amoxicillin, 70%. Now, of course, you could go with a dual agent, right? You can go with the Remeron plus the Haldol. Remeron plus the antipsychotic. But we're not going to ask you that on the job. We want that's your knowledge of that dual mechanism of amoxicillin, single agent. Questions?
So to clarify, dual mechanism works as an SNRI and D2 receptor.
Antagonist.
Yeah. And, sorry, I like that. 70% of patients with MDD with psychosis get better when given.
When given both, say the combination of antidepressant and antipsychotic therapy, whether it's dual agent or a single agent. If you do both in a single pill, in 2 pills, if you do both, 70%.
Oh.
But in retracting that now, it's probably still not the best thing to do for your patient. So piggybacking or holding back to your question, no, it doesn't have to be a medication.
Crystals for sure.
That would be something you would.
Do
Yes, 90% get better here. Right, 90% get better there. So even better than 7. Anything further to discuss with Amelia?
I think she would also benefit for services for Samuel. Like testing or just, she needs help with it. I think that really exacerbated her symptoms as well.
Yeah, I mean, I get the bridge there too, which, again, would be addressed in therapy, would be that his birthday is the death day of her husband, and when she looks at him, she can't help but, think of her husband's death and blames him, which is incredibly anti-maternal, right, which is a layer to this that, nobody can see. Very difficult for her to process that. Again, we're gonna skip over Samuel. Don't have much to say about him, because I just don't know anything to say about him. Other than obviously he would need help. Yeah, for all services. Anything else? Any other observations as we want to talk about? What if I told you everything we discussed up to this point is wrong?
Putting the pharmacology.
That part, right. We got the pharmacology right, unfortunately, for the wrong reason.
Yeah, she doesn't have to be.
Correct.
I don't think the other way. It's a kind of, spectrum disorder.
It could be, it could be. And this one, I would expect, this is a bit of a hint. The blue team, to have a better chance of guessing where I'm going versus the red team. That's a hint. Something like that. Ooh. Here, I like where you're going with this.
Oh, the neighbor, that is actually happening, the neighbor, the matching.
What's going on?
Like some kind of dementia, and she's like seeing her neighbor, and she now has this conspiracy that they're being chased by Babadook, and like that's why she knocked in the house so late. She was so worried because that's like a delusion.
So why would Mrs. Rhodes think that? She have dementia? Why do you say Lewy bodies?
Is it because of her motor issues? Her motor issues too, you know, there's difficulty walking at sometimes.
He's actually written as having Parkinson's and stress.
I didn't say that about it. She tells the mom. Yeah.
And it's,
So she has Parkinson's dementia or Lewy body dementia, and all of what we see is through her perspective, not Amelia's, not even Samuel's, because visual hallucinations are part of Lewy body dementia. Mrs. Roach. Okay. If you look at the actual definition of dementia, I'll post this on Instagram on yours. You can actually rearrange the diagnostic criteria to spell Roach. Now, we recently, just about a week or so ago, provided a seminar about the neurocognitive disorders through selected works of Shakespeare. And we looked at delirium and Macbeth, and we looked at the dementias, major as well as mild neurocognitive disorder through King Lear. And there's an acronym within King Lear that works just as well. So I'll post that on Instagram. We don't have time to go into delirium, going off on that tangent, just trying to figure real fast about dementia. In this case, I think Parkinson's, dementia or Lewy body dementia, which of course, again, would be synuclein dystrophy. So blue team, now your gag. What other mental disorder that can appear on a psych shelf has a relationship with Lewy body dementia, and why?
Maybe that's a medical condition.
What is REM sleep behavior disorder?
That's really like a manifestation. It can be a manifestation of like a neurocognitive sort of.
Yeah, it's a synuclein dystrophy, which is the same etiology as Lewy body dementia. So individuals with one have risk for the other. And when you rewatch this film with an idea of, hey, listen, is there any REM sleep behavior disorder in this movie? You'll view it differently. Right? Because again, if anything that affects or anything that results from a REM pathology will be remembered. And you just wonder if this whole thing is one big mess. This is what. Final thoughts? Like generally speaking, for dementia, again, treatment's biopsychosocial, but there's a couple of girls here. Number one, in terms of the biological treatments, the focus is primarily to increase acetylcholine. Most medications do that. The other medication, Namenda, has a mechanism of action that is outside of that. Namenda will actually decrease CNS glutamate. Okay, so usually we prescribe both simultaneously because there are two separate mechanisms of action. Neither really reverse the course of the illness, of course, but we just slow the progression. Yeah. No.
It's a generic.
Namenda.
Memantine? Yeah, that's what.
The other thing I just want to briefly mention too is that caregiver burden is a major deal here. The prevalence of depression in the primary caregiver is among the highest among all chronic illnesses.
It increases risk for elderly as well. And caregivers are not-
And I know that most of us have an automatic thought, keeping in mind the CBT, have this automatic thought that individuals with this condition, because of the chronicity end up in nursing home. The majority actually would care more by the child in the home. And that certainly contributes directly to the level of caregiver burden, which again is among the highest for any chronic illness. Final thoughts, questions? Any particular topic you want to cover next week? Name the topic, and I'll try to figure out the movie.
We talk about antipsychotics, all of the side effects, maybe some niche indications, just kind of navigating antipsychotics. Something else.
Absolutely. So I'll post later on today on Twitter with the movie will be. I'm not gonna get anything away, but it'll be something that I can tie your request to. I don't want to get anything away. All right. Thank you, guys.